Interesting.
Good afternoon, and thank you again for inviting me to the stage. You've heard an amazing morning of shoulder surgery, but if we don't end and talk and be critical to ourselves about the biggest problem, which is infection, then everything we heard this morning means nothing. And I'd like to share with you that it is on us, it is not on our patients that we're making the mistakes, I think. Shoulder surgery is devastating when it gets an infection. You think the rate is low, take one patient and follow them through their lifetime. It changes their life. And there's so many causes, and whether it's arthroplasty or arthroscopy, it does happen. It could be septic arthritis that turns into an early arthroplasty. The high costs in America, you can see some of the issues, and the lost wages because of infection or even no infection. Database studies, whether published in American here, the Orthopedic Sports Medicine Society, a 90-day infection rate seems low of 0.26%, but can be dramatic, whether it happens for whatever type of procedure that you see. Here in Journal Shoulder and Elbow, again, 2,000 primary reverse shoulder arthroplasties, mean age in 74. Look at the bugs that are coming out. And it's all a history in these of a rotator cuff repair. They said that claims that it increases prosthetic joint infection after RSA. And is it true or not? Here, another journal article from the American Academy of Orthopedic Surgeons. In pearl diver studies, history of infection increases risk of infection. And will you now do that total shoulder or the reverse the second time around? And how will you clear the patient before you do it? So, what is that definition of infection that we hide in the literature or not? I'd like to say that we again have to come together to talk the same language. Is it a superficial infection that you treated just and watched? Did you give antibiotics for a deep infection? Did it affect another organ system? And again, if in the literature we all agree on our definitions of infection, again, I think we can eradicate some of the infections, and we'll talk about it. The common pathogenic organism is here, C. acnes that we know. It's the most common cause in shoulders of deep infections. And the problem in my own hospital is they throw away cultures in 2 or 3 days, and you know it takes longer to grow it. Staph epi, number 2, and Staph aureus here you can see. What do we look for? We look for, high sedimentation rate. And I'm going to show you how I think you can prevent some of these infections in a minute. C-reactive proteins, white blood cell counts that I worry about, greater than 10,000. And it's an aspiration of the synovial fluid. Excuse me. Gram stains that grow, it's a slow organism that grows. And it requires that 14-day incubation. So you have to write down on your prescription that you're going to hold this culture and wait and see what grows. Risk factors, here they are. You heard this morning some doctors said they're not going to operate on certain people for reasons. Smoking is an 8 odds ratio. Male gender versus female. Nutritional deficiencies. And it moves down, and it may be higher in reverse shoulder arthroplasties. Diabetics for us is bad in the south and the southeast of our country, and revision surgery. Hear about malnutrition, 421 primary and 71 reverses. You see the prevalence here of malnutrition patients in revision and primary. It's a prevalent factor that's modifiable that we can with our patients. And think about it before looking at albumin and calcium rates and others. Great article. All these QR codes you can take pictures for. Journal of shoulder, does timing matter? So here are big smokers, non-smokers, current smokers. I think we figured it out that unfortunately smoking has a major effect of infection and risk rates. Look at the odds ratio. Even if someone stops smoking for 6 months, we have to counsel our patients to think about removing smoking in their world environment. It's difficult in different parts of the globe, I get it, but it does reduce infection in your hands for your patients. So the literature suggests that there's a pre-op arthroscopy if you do it, then later an infection. And here you can see various articles that were published for prostatic joint infections. And so the recommendation has been if you're going to do an arthroscopy, so they say, prolonged surgery by 3 months following this, and then you can go ahead with a total joint or reverse shoulder arthroplasty. So here's another article looking at biopsies, arthroscopic biopsies, findings. What is the status here and the quantitative distance for an analysis of infection rates, and you can see the sensitivity and specificity. It's about getting a piece of tissue to really confirming the infection and then not hiding it, then treating it and dealing with it. Many times we put our heads down. Is there a link, though? I wanted to look in corticosteroid infections, injections and infection. So, is there a possible link between infection and these injections that we give our patients to make them feel better? And what is it? Is it the database that you're looking at? I don't believe so. I'm going to shock you a little. Is it the agent? Is it the route of administration? Was it in the same shoulder? Some of these databases are just not accurate in giving us data. And so I'm going to show you, here's what they say in the database. Prostatic joint infections, if less than a month, you 1 year, there's your odds ratio. So be careful, don't inject, don't do a prosthesis. There's definitely a clear indication in the literature of the number of corticosteroid injections that you give and an increased risk of infection. And it's 2 or more bumps up the odds ratio. So I would encourage it's one and done. You get one injection in your life of corticosteroid, you don't come back. It's time for the operation if you need to do it. Or let someone else get the infection. So here in our series of 159 shoulders, we looked at no injection group, preoperative, 97, 62 patients with an injection, all anterior injections, 25 gauge, 1.5-inch needles with Celestone. I have no variation in steroids. I don't own any stock. And looked at how many people got one injection and looked at when I even gave 3, which is terrible. And the average time to infection to surgery here, seeing this, and pre-op, there was some correlation. It's coming. But there was no infections at the first time of our no injection group versus injection. So statistically, while we had injections, there was no difference between the people that didn't get injections and people did get injections. So I don't know what to do really with the data. Is it really the corticosteroid? Is it someone has a smoker and other things? We're looking at it. It's brand new data. So I will tell you, though, in the subgroup analysis, we looked at patients that had an injection less than 1 month before having a primary rotator cuff repair. So this is not prostheses. We had no impact if it's less than 1 month. So I'm unclear in my advice. I know what the Pearl data says. I love to be skeptic about it. Look in your own practice. Is it the injection of the steroid? Is it the protoplasm of the patient? Don't know. So here we can see when to cut bait, when should you wash out. My answer is, like the other lecture I give, it's early. Don't sit on things. So when do I go to the operating room? If there are any cells in the aspiration site of infection, I'm going to go to the operating room to clean out that joint so I don't have a lifetime problem. So let's see what works and what doesn't work, and let me solve that. Preoperatively, we always thought hair removal, very important to do. We're going to talk about it. Skin surfaces, what you clean with. Is there a role for laminar flow? Post-op dressings. Let's get to it. So preventing infection, hair removal. They say it clears obstruction, minimizes contamination. Removal of axillary hair, no effect on C. acnes. And I do remove axillary hair, and I'm telling you, hair removal, we now know, should only occur if obstructing the surgical field. And never remove it in the operating room. Remove it in the preoperative area. There are plenty of studies that now prove to decrease infection about hair removal. Skin surfaces, what do you use? Well, you want to decrease the bacterial load. So what about benzoyl peroxide And what about hydrogen peroxide? Here's some articles, some great articles. Greg Bain down south. Dermal chlorhexidine does not, and I use it, eradicate C. acnes during surgical prep. That's in the United States what we now have been using. It shows that it doesn't get rid of it completely. It gets rid of it, it lowers the load, but not completely. Preoperative benzoyl peroxide in the United States is young children who have acne on their face. It turns out versus chlorhexidine gluconate, it's only benzoyl peroxide that is the most effective in reducing C. acnes, now seen in the literature clearly. And so in my operating room, I absolutely rub on benzoyl peroxide, Oxy 5. I don't own stock, and we rub it in before we do our procedure with the chlorhexidine, with the antibiotics as we talk about. And my patients wash 5 days before with chlorhexidine before I go to the operating room. Here, a randomized control study. Hydrogen peroxide is inexpensive, effective as an antimicrobial agent, and you should incorporate it, in my opinion, in standard sterile preps. This has been shown as well. Easy to do, high yield, low cost. How about laminar flow? It does give positive pressure air measurements, directs air streams, theoretically decreases airborne particulates. In preventing infection, it may prevent infection, but the cost is so high, even when doing a total joint, that is it really worth it? It's not been shown now financially to be worth doing any total shoulder reverse in a laminar flow room, which is great for many areas in the globe that can't afford these. And so you're in good stead. Skin knife blade. You're supposed to replace the skin knife blade after incision for deeper dissection. That's what all my mentors told me. Theoretically, stops the skin barrier here. There is no evidence to support changing a knife blade after skin incision, and yet I do it. I was taught to do it. I was beat up to do it, and there's no evidence to it. And specifically, shoulder-specific evidence is needed, just so you know. How about single-use instruments? Minimizing instrument contamination improves efficiency, decreases OR time. Single-use instruments may, in fact, reduce superficial infections. It's unknown in total knee arthroplasty. More studies are needed. What I will tell you makes a difference is putting a tape, as I do on the door, and don't let anyone in and out of your operating room. And we have a problem with unions in the United States because they have to take breaks. How come I don't get to take a break in the middle of my operation? Why does my nurse get to take a break? Why does my scrub get to take a break? The point is stop the traffic, only you, only your team, and demand on it, and you can decrease infection. Vancomycin powder yields high local bactericidal levels. It's poor systemic absorption. It's low cost. The question is, should you throw this in for your reverses and your total joints? Here you can see in an in vitro study that intra-incisional vancomycin application may limit C. acnes for prosthetic joint infections. Here, a retrospective study, another one on 827 total shoulders. Intraoperative vancomycin powder did significantly lower the risk of infection, in fact, in this study. Here, is there a role for the dilute betadine? Be careful, you have to have it sterile. 8,477 primary joints. It came from the hip and knee literature from Jay Pavrisi, a dear friend who's just announced, sadly, his retirement. And pre-closure betadine effectively lowered in the knees and the hips prosthetic joint infection. Should we do that in our totals and our reverses? Here, staple versus suture closure, there's a bias here. No debate. Staples increase the risk of infection way up for relative risk. Don't use staples. Take the time, throw your subcuticular stitch in. It's safe and decreases the risk of infection. How about post-op dressings as I end? They make these high, incredible new wound closures. They're very expensive. They do work, but they cost a lot of money. So in summary, the risk factors for infection here, Think about your patients for smoking, prior joint infections, male sex, malnutrition, revision surgery. Our data demonstrates for us preoperative corticosteroid injections do not change it. And sorry, they took the bottom of the slide, and my memory, because it's 3 in the morning for me, still is not there. But it said something that basically we should own the problem, please. Don't throw it all on our patients so we can hopefully have great results in the future. Thank you for letting me share.